Okay, I think it's 1 o'clock and I think we should get started. So good afternoon, welcome, bonjour, bienvenue. I hope this is going to be a very exciting session on the missing men. I was just looking at the panel and the audience, and I think we are predominantly women and the men are still missing. But anyway, there are some here, so men, you need to speak up. So I think we all know from the UNAIDS report that was published in the last week and from all of our work that we are struggling a little bit to find the men. And so we've got an interesting panel discussion ahead of us to look at what the issues are, whether the men are indeed missing and what we can do about it. What we'd like to do in this session is that we would like the presenters, they're going to have 5 minutes each, they're all going to be very quick and to the point. We're going to run through all the presentations at once, and then hopefully we're going to have half an hour when you can ask all of your questions and we can get a good discussion going, I would hope. So please jot down your questions, get your pens and papers out so that you can write questions so you don't forget them by the time we get to the end. So let's get started. Our first speaker is Dr. Gail Claquin. And Dr. Claquin works with the Mozambique-based NGO Friends in Global Health in Mozambique, and he's got over 15 years of global health experience working with governments and donors towards quality improvement. So, Gail.
Thank you. Good morning, everybody. So, let's start. Sorry. So I will be presenting today on behalf of Aima Ahonghai, who is a deputy professor of infectious disease with Vanderbilt University. And so Vanderbilt in Nashville, Tennessee, USA, has created Friends in Global Health, who is an NGO I work for with some colleagues there or in the audience, in central Mozambique, specifically Zambezia, who is the most populated province, highly affected by HIV, and harboring also very major difficulties in terms of poverty and infrastructure. And so the speech today is regarding the analysis of retention and access to care in youth population that we serve in this rural population, and looking at the sex disparity. So the objectives were to analyze retrospectively the performance at key steps along the HIV continuum of care for female and male adolescent and young adults. We therefore conducted that retrospective study targeting the 15-24 years old age group in the district that we were serving at the time in the province, which are roughly half of this big province. So the total is 89 health facilities, and the period of analysis is 2012 to 2015. So in order to conduct this analysis, we can look first at the bottom line. We analyze referral sources, which could be diverse. The CD4 cell count, there was no viral load in routine at the time, which then conduct us to have the pre-heart loss to follow-up rate, which is defined as less than 4 consults during the 6 months period of follow-up. And also post-heart loss to follow-up, this time defined as more than 2 months delay after the scheduled pickup, which is generally used in several countries. So from this, we will be able to show you the time to heart initiation and the 1-year mortality in particular. So in terms of results, we were able to analyze more than 23,000 files, and mostly women, 83%. Regarding the result in terms of diagnosis, women were mostly referred from PMT-CT services, while men were mostly coming from VCT. 11% of men, meaning generally a couple, showing up at the PMT-CT services and being therefore referred for care and treatment from this point. Regarding the CD4, we can see that there is a significant difference we'll analyze later on between men, showing up with lower CD4, which is in line with what others have been publishing, and 100 CD4 lower than women. In terms of access to heart, the delay for initiation is very short for women, and we can understand why, looking at PMTCT, but can be pretty long, up to 160 days, with a median number of days of 34 in men. In terms of loss to follow-up, there is also a major difference. The mean is already high in this youth population, but for men, it reaches very high level, even pre-heart. And the difference, if we look at adjusted data, is even more striking. In terms of post-heart follow-up, in fact, raw data tend to show rather similar percentage, but again, adjusted, this is highly significant, showing more loss to follow-up in men. And finally, for mortality, the data are showing 1.6% mortality at 1 year for women and a high 6%, highly significant for men. But it's a bit small here. We have been using a nomogram that we can discuss later, but that takes into account mortality in loss to follow-up. And according to that nomogram, which has been established based on several cohorts and published, the mortality would be 17% in men and could be as high as 12% for female. So, conclusion to this analysis is that, obviously, the majority of young adults and adolescents enrolled are women. This happens mainly through PMTCT, and women therefore present with higher CD4. Retention is overall poor, but the difference between male and women is really striking in favor of a woman better retention. And we also could analyze that the peak of this low retention is at 20 years old in male, and we can discuss maybe this after. So mortality was found to be potentially very high if we use available data and models. So therefore, we feel as implication that there is a need to obviously offer more services to women regarding their access to care, but that also male, in terms of their engagement and retention, need also special attention and have needs that probably are still uncovered. Thank you for your attention.
Okay, thank you. So our next speaker is Njambi Njuguna from Kenya. She's a researcher with over 7 years' experience in the field of HIV, and her main interests are in HIV prevention and care amongst key populations, and she's speaking about gender age considerations in Kenya.
Yes, good afternoon. So I'm here to present on behalf of Samuel Muga, who could not be with us today. I have no particular topics, conflicts of interest. So I'd like to present our findings on the gender age considerations and likelihood of viral load suppression at subnational level in 5 counties in Kenya. These are data from a large care and treatment program, USAID funded, that provides care and treatment facilities for HIV-infected persons in Kenya in the Rift Valley region. This has 5 counties, large region in the Rift Valley, 5 counties out of the 47 in Kenya. So it was a retrospective study of data records abstracted from 139 facilities in these 5 counties from October 2015 to September 2016. The slides are not there. These records were looked at to look at the distribution of persons with the age, and we wanted to see whether we can be able to look at the correlates of viral load suppression when it comes to age and gender, with our viral load cutoff being 1,000 as per our national guidelines. Below 1,000, we consider you virally suppressed. So what did we find? we found that at subnational level, in the 5 counties, which had very varied populations, from as large a county of 22,000 persons on treatment in Nakuru to one that has fewer, like 2,800 in Baringo. The majority were older persons, 25 years and above, with very few being, almost none, being under ones at that particular point of time. And, well, female gender were the most, representing about 70% of the population and of all the clients reviewed. When we looked at the viral load, generally, women were more virally suppressed than the men, about 16% more virally suppressed than the men, but this varied significantly when it comes to the counties. So this graph shows viral load comparison with all the age groups compared to those who are 25 years and older. And the ones that seem to be doing the least well or the most poorly were the young ones, the under ones. And this was consistent in all the counties except one, where they had the same viral load suppression rates as the comparison group, which is the adults over 25 years old in Baringo. That's the last one on the side. And when we looked at this by the different regions, this meant that, and even by the different ages, there were some variations whereby, like for example, when you look at this table, we had persons who were compared in the 5 counties in the different age groups. So some counties seem to be doing much better than others, where we have females having the same suppression rates as male when it comes to the under one. But when you look at a county like Nakuru, yes, so females were much more likely to be suppressed than males of the same age in certain counties, like Nakuru, in the 1 to 9-year-olds, or when we come to the 10 to 14-year-olds in this county, like Kipia, it was about 2 times more likely to be suppressed than the male counterparts the same age, and the same for Narok. And we found that this was interesting because the interventions that we implement in Kenya, we don't really consider the gender or the age disparity. So we talk a lot about the age-gender disparities. We talk more about the gender disparities rather than the age. And the likelihood of giving the same intervention everywhere may not be working as well, because perhaps we need to consider the region where this is working. So this study or this analysis showed that in as much as the men are missing, they're not missing the same way everywhere, and they're not missing in the same way in the same age groups everywhere. So one of the things that we are considering within the program is the different approaches to viral load suppression or viral load activities to promote viral load suppression based by gender and age, and even by geography. Thank you.
Thank you very much. So our next presenter is Kelly Curran, who's the Director for HIV and Infectious Diseases at JPIGO, where she leads a team implementing HIV prevention, care and treatment programs in 17 countries. And she's going to be talking about partner notification in Tanzania.
Thank you so much for that kind introduction. Good afternoon, everyone. It's a pleasure to be here. I'll be presenting on behalf of my co-authors from the National AIDS Control Program in Tanzania, USAID, and JPIGO Tanzania. And I also understand that the Permanent Secretary from the Ministry of Health of Tanzania may be in the audience, and if he is, I'd like to acknowledge Dr. Mpoki. Thank you. I'll be presenting today a sub-analysis as well as the qualitative component of a study whose main findings were originally reported out at CROI in 2016 and published in AIDS and Behavior in March of this year. And the main finding of this study, which was conducted in 3 hospitals of a very high prevalence region in Tanzania, found that partner notification using an index case approach was highly effective in reaching previously undiagnosed individuals. In fact, almost 62% of the successfully referred partners of the index cases in this study were eventually tested positive. I'll walk you through quickly the results in this flowchart. And you can see we ended up disaggregating our data by sex to look at differences in partner notification. Men are on the left and women on the right. And while there were more female index clients than men, you will see that men were more likely than women to enroll in the study. They were more likely than women to list more than one sexual partner. They were more likely than women to successfully refer at least one sexual partner. And the female partners of the male index clients, 66.4% of them ended up testing positive. The male partners of the female index clients, 57 or close to 56% tested positive. None of the participants in this study reported same-sex sexual partners. Now looking at the odds ratios, we'll see that men were 6.2 times more likely than women to list more than one sexual partner at partner elicitation. Men were 2.2 times more likely than women to successfully refer at least one listed sexual partner. We also disaggregated our data by relationship status, and we found that married clients were 2.5 times more likely than single clients to successfully refer at least one sexual partner. And all three of these findings are highly statistically significant. Moving on now to the qualitative component of the study, we enrolled 46 participants in a qualitative component. They each provided an in-depth interview. These participants were evenly split between men and women, and half were index clients, half were successfully referred partners of index clients. And three main themes from the qualitative work emerged. One was around barriers and facilitators to testing. So both geographic distance and absence of symptoms emerged as a barrier to testing, especially for female index clients who were attempting to refer their male partner to testing. Many female index clients mentioned that their partner had migrated for work, or that they had even disclosed their HIV positive status to their male partner, but that he explicitly stated that he would rather wait to see whether he developed any symptoms of HIV before going in for testing. As I previously mentioned, the type of relationship was very closely correlated with success at referral, with marriage being much more likely to lead to successful referral than a casual partner status or even a boyfriend and girlfriend status. We also found some interesting things around the language used in notifying sexual partners. So to give two examples, the top example was a female index client who was 39 and married, and she said, "I called him," meaning her husband. "I told him that you are needed here at the hospital. He asked, 'What for?' I told him to come because they have told me that I have anemia. You have to come for you to get the information by yourself. They need to tell you many things." So in this case, you'll see that she didn't actually directly disclose to her husband that she had tested positive for HIV. She instead told him that she had anemia. But this strategy actually did lead her to successfully refer him. He did come in and he ended up being tested for HIV. The second example is another female index client. She's single and 28, and she was actually one of only a handful of women in this study who listed more than one sexual partner at partner elicitation. And she said, "Even if I recall them, it won't be easy for me to give them this information because others have their own families already. We just met as friends for a day. If you meet someone just for a day, do you think you can tell him this matter?" And this issue of women not being able to interfere in the relationships with their male partners who may have been married or had other sexual partners came up over and over again in the qualitative work. It was as if the women, not only did they not feel that they had the agency to inform those men, it was almost as if they didn't have the right to interfere in his marriage in such a way, even to disclose something as important as possible HIV exposure. So in conclusion, as we've previously reported, partner notification using an index client approach in this high prevalent setting of Tanzania was highly effective at reaching a large number of previously undiagnosed individuals, with about 56% of male partners and 66% of female partners ultimately testing positive. We saw that success at referral to HIV testing services varied quite a bit by sex and marital status, with male index clients being 2.2 times more likely to succeed in referring their female sexual partner, and married index clients being 2.5 times more likely than single individuals to refer their sexual partner to HTS. We'd also encourage, I know that partner notification is in the process of being tremendously scaled up in the region right now, and we'd encourage programs that are implementing partner notification to do formative work to try to understand some of the gender norms that may affect the experience of male and female index cases during this process. Thank you very much.
Thank you very much. I'd like to introduce Carolyn Ade. She is an assistant professor in the Department of Health Policy at Vanderbilt University. Her research has focused on the integration of traditional healers in healthcare delivery and the inclusion of male partners in antenatal delivery and postnatal care in Mozambique.
Thank you very much. I'd just like to thank everyone for coming today. My talk today is about male engagement strategies that are effective in improving Option B+ retention in rural Mozambique, and I'm presenting on behalf of my co-authors listed here, and we were funded by the National Institute for Mental Health and the CDC. So the objectives of our evaluation were pretty simple. We have a male engagement strategy that I'll describe in a second, and we wanted to compare the rates of retention among pregnant women who are HIV positive and their male partners who enrolled either in a male engagement strategy for PMTCT or who enrolled in a standard of care clinic for PMTCT. Our methods were a retrospective cohort study of women who were 15 years of age or older who enrolled in HIV care and treatment from 2014 to 2016. And we had data from 112 PEPFAR-supported Ministry of Health clinical sites that included 6,500 pregnant women. Okay, so the male engagement strategy, so everybody understands it. I'm going to pick on Sarah, who's sitting here. Imagine that Sarah is pregnant. In rural Mozambique, especially in Zambezia province, she's most likely to first see a traditional birth attendant for her antenatal care services as opposed to the health facility. So we decided to engage the TBAs, train them about antenatal care services, prevention of mother-to-child transmission, and counseling. So how do you present this information to the pregnant woman? At the same time, the TBA will get permission from the pregnant woman, Sarah in this case, to contact her male partner to give some information to the male partner as well. So if Sarah gives permission, the TBA will contact what we call a male champion. That male champion will then go visit the husband at home and pass on information about antenatal care services, pass on his congratulations, and say, you know, what would be really great is for you and your wife to go to antenatal care services together. And that way you can better understand the pregnancy, but you can also get HIV counseling and testing at the same time, which is great. Also, the reason we decided to do it this way is that male engagement in ANC has been highly stigmatized and isn't considered normal. And so with having this male champion and the TBA, what we decided was everybody would go to the health facility together until this was destigmatized. So you end up with 4 people going to the health facility for the first ANC visit. And then after the first ANC visit, the male champion continues to contact the male partner, and the TBA continues to contact the pregnant woman and after delivery. So the results, we started this in one district, 5 health facilities in 2012, and have scaled it up now to, I think, 34 health facilities in Zambezia. And if you look at loss to follow-up among women who are enrolled at male engagement strategy sites, whether or not they brought in their husbands, so it's an intent to treat analysis, versus non-MES sites, they have a lower rate of loss to follow-up, or lower hazard risk of loss to follow-up. So I should have said this before, but we actually picked the worst sites to start the male engagement strategy first. This was not an RCT by any stretch. We sort of identified sites that had the worst cases, and that's where we rolled out male engagement first. So pregnant women have a 23% lower hazard risk of ever missing medication pickup in the first 6 months, and that's after adjusting for district, education, marital status, language, BMI, and CD4 cell count. What I was really excited about was that essentially the longer we have male engagement strategy functioning at a site, the better, the lower our loss to follow-up is in those sites for pregnant women. So every 7 months of operation, basically the women are 29% less likely to miss medication pickup than those not enrolled in MES sites. So you can see here, this would be a retention probability in a site that's been going on for about 3 years. This is 12 months. This is no male engagement. So in conclusion, the male engagement strategy employed in Zambezia has resulted in significant improvements in the retention of pregnant women on ART. women who attended MES clinics were more likely to remain in care 6 months in comparison to those who attended standard of care clinics. The longer a clinical site was included in the MES strategy, the better the retention of pregnant women. But I didn't present this, but if anyone wants to talk about it later, the impact on male partner uptake of ART and retention, if they're enrolled through PMTCT, it's not really very clear that this is a great idea for men, the way we're doing it, so we need to further investigate that. So the implications are that engaging male partners is important, but we need to figure out the best way to do it so it helps both the woman and the man. Thank you.
Thank you. Next, I would like to introduce Ryan Britch, who is going to be speaking about circumcision and HIV testing among men in Luau.
Good afternoon, everyone. I appreciate you all attending today. My name is Ryan Britch. I'm an American Peace Corps volunteer. I'm stationed in Swaziland, and I'll be presenting information we've researched on my organization, Gwaka and Votsa. I have no conflicts of interest to declare. So Swaziland is one of the most gender unequal countries in the world. Approximately 1 in 4 females experience physical violence before the age of 18. In addition, 1 in 3 experience sexual abuse before the age of 18. This is coupled with the highest HIV prevalence rate in the entire world at 31% of adults. Women and children bear the brunt of this coupled epidemic. This underlying gender inequity impedes every other developmental goal. In response to this, we see women's social movements and health interventions making progress and creating a more safe and fair society everywhere we look. But there's this one vital puzzle piece missing. We are not involving men. VMMC demand in Swaziland remains extremely low. Men continue to report fear and suspicion to the procedure due to the solely biomedical approach. Behaviors of young men, especially how they aggravate and perpetrate abuses against women, are often overlooked. Very recent data shows 40% of Swazi men believe if a woman wears a short skirt, she's asking to be raped. Half of Swazi men believe a wife cannot refuse to have sex with her husband. This, in turn, affects the levels and acceptance of gender-based violence, including sexual violence and the socialization of multiple concurrent partners, transactional relationships, and intergenerational relationships. I believe we need to ask ourselves, what have we done to encourage positive masculinity? In response to this situation, Gwaka and Votsa has implemented our flagship project, Lihao Male Mentoring Camp. We offer 15 to 25-year-old young men a comprehensive package of adolescent male mentoring and health services and interventions. Lihao is a 3-day residential camp aimed at combining behavior change tenets of traditional Swazi and Bantu initiation rites with clinical best practice in VMMC. Using traditional techniques and modern medical practices, we seek to create a conducive, positive third space for VMMC clients to engage with mentors and peers in a fun way. We demystify myths and misconceptions about male health issues, masculinity, and male circumcision. Utilizing youth-friendly fun activities, including outdoor challenges, edutainment games, uses of art and cultural observances, we seek to sensitize young men on positive masculinity, gender awareness, goal setting, HIV, and male health issues. You guys can see in some of the pictures, we have the Esangweni, the young men have gathered in the kraal around the fire. They're eating in Slogo, which is a traditional initiation rite for when a young man becomes a man, he eats the head of a cow. So at the end of the 3-day camp, participants are offered a package of male health services, including HTC, VMMC, as well as STI checks. We check for diabetes and TB, and we provide classes on nutrition. So measuring from pre and post-test anonymous surveys, we have detected here a 33% increase in gender equitable beliefs, 21% increase in acceptance of gender deviance, 26% increase in knowledge on condom efficacy, and 44% increase in knowledge of post-VMMC care and conduct. On the graph on the right, our participants, 87% of them have utilized HTC services compared to the 26% who acknowledge on pretest that they did not know their HIV status. At the end of the camp, 86% of the young men participated in VMMC and became circumcised compared to the national average of 19. I appreciate your time. Thank you.
Our next presenter, Laura Fuente Soro, is a PhD candidate or student in Mozambique, and she is going to be speaking with us about the HIV care continuum in that setting.
Thank you very much. I'm going to present this study entitled "Men Are Absent Across the HIV Continuum of Care in a Rural Area of Southern Mozambique," and I will present on behalf of my team that is down there. So, loss to follow-up along the HIV continuum of care increase morbidity and mortality, but is not equally distributed by sex, and HIV-infected men experience substantially worse outcomes than women. HIV diagnosis and initiation of treatment are delayed, treatment adherence is reduced, and mortality is higher. Adolescents, girls, and young women are at particular risk of HIV infection and are often infected by older men. So this analysis aimed to assess the sex difference in linkage and retention in HIV care in the Manisa district, which is located in the south of Mozambique. This study was nested in a larger prospective cohort study conducted in the Manisa district between May 2014 and June 2016, and enrolled consecutively adults with a new HIV diagnosed through 3 different testing strategies: voluntary counseling and testing, provider-initiated counseling and testing, and home-based testing. In this case, home-based testing was able because in the Manisa district, the Manisa Health Research Center have a demographic surveillance system, so we randomize the adult population and we visit them at home. If you want to see further information, you can see that poster also that explains the main results of the study. But for this currently analysis, we assess different steps of the cascade: HIV diagnosis just for the home-based testing group, and then linkage, initiation of ART, retention, and mortality for the 3 groups. This first graph shows the age-specific community HIV prevalence according to sex and age in the home-based testing population, around 11,000 people. The community HIV prevalence was estimated around 33.6, and if you can see, there are some groups that are especially at risk, which are the 35 to 45 and has the highest prevalence. You can compare female are around 40% versus men who are 26.6. So the difference is higher between sex and age. In this second graph, we want to go ahead and see the proportion of people who are by sex and age aware of their HIV status. And in this graph, we saw the difference between the differential proportion between male and women. So we can see that here, principally, young men are lagged behind women at the same age on reaching the first 90 target. The overall proportion of awareness in men were 76.8, versus to compare with the 89% of women. Out of the population that were enrolled in the study, men were less likely to be linked to care and receive a CD4 result. 5-fold more men than women were in advanced stage during the first clinical visit, and among those individuals who were eligible for AAT, similar proportion of men and women start treatment. In this case, in this graph, we saw the proportion of loss to follow-up over 18 months after initiation of antiretroviral therapy, and male were almost 3 times more likely to be lost to follow-up in the continuum. We also see the mortality, and after 1 year, the mortality was almost twice in men than women. So, in conclusion, finally, to decrease mortality in men and achieve the 90-90-90 objectives, we will require male-specific strategies and male-friendly approaches for testing, linkage, and retention across the continuum may improve clinical outcomes, and also we thought that we could decrease the transmission to young women. So, thank you very much.
So I'd like to thank all of the speakers for some very interesting presentations. And now it's up to you in the audience. So please, if you've got questions or comments, if you could make your way to the microphones, it would be good if we could get a good discussion going. Whilst you're moving slowly to those microphones, maybe I can just ask Ryan a quick question to set us off. Ryan, I was just wondering how many men have been through your camps and whether you think these are scalable.
Yes, thank you for the question. As of today, we've put over 600 young men through our programs, and yes, they are very scalable. We work through USAID, through PEPFAR, and through CHAPS, and all of the programs would be scalable for national and international size.
Great. Okay. Let's start at that microphone. I saw you first. If you just introduce yourself, and if it's to anybody specifically, say who it's to.
Hi, Chris Gordon from NIMH. Great set of presentations. So I think this question is mostly for Carolyn to start with. You know, men are awful, that's clear. But are you aware of anything going on significantly to decrease rape? You know, it's not a space that we've funded a lot of work in before, but as we work more with men, we can certainly do positive things, right, and try and help in some ways. But I'm perplexed myself about how to change something that seems so culturally okay.
So I don't know that men are entirely terrible, but so we've addressed it in 2 different ways. The first is when we did the first male engagement strategy pilot, we used a gender equitability intervention that essentially was working with men. I mean, it sounds crazy, but help your pregnant wife, make dinner and help her do the laundry and don't beat her up while she's pregnant. And, so there was like some specific things about just sort of how to engage with your wife. And actually she's a person, so let's talk about that. And we did have a lot of feedback coming in from wives asking if we like bewitched their husband, but in a positive way. And so that was a good thing. And so certainly, while we didn't talk about rape specifically, it sort of all came into a package. The other thing we are doing is we have a CDC subcontract to look at rape in almost all of our health facilities, whether it's with kids or adults, and to try to mitigate. It's funny because we've done a ton of radio work talking about rape and community interventions with leaders and police, and just sort of any important men and women in the community to get the discussion going, because I don't think anyone was talking about it. And so that's increased the number of people who are coming into the health facility saying they were raped. Primarily it's kids that are coming in, and so unfortunately what I think is that women who are raped don't even consider it to be rape, or at least not anything that they need to seek healthcare services for. So in a way, I think what we're doing is at least creating the understanding within the community that raping a child is an unacceptable behavior and that the parent of that child should be outraged. How that's actually working with adults, I'm not sure that we have that information. So okay. I would say soon I'll have data for you, but not yet.
Okay, can we go to this first?
Hi, my name is Gaston. I'm from Argentina, and I belong to the Argentinian Network of Youth and Adolescents Living with HIV. And my question is general for everyone regarding especially straight males living with HIV, because we have such a difficult time in the organization I belong to, working and engaging straight males living with HIV. And I was just wondering whether you have or have not, and if so, how differentiated between those populations in a way that it can contemplate their own specificity. Because I've been to many key population presentations in these 3 days, and they all speak about LGBT community, transgender, and there's no mention about straight males. And those are my missing men. So I wanted to know what you had to say about that.
Thank you. Yeah, I think we tend to be in different groups. But yes, who would like to take this? Kelly? Yeah.
Maybe not necessarily pertinent to my presentation, but I think this is something that there are opportunities for engaging heterosexual or straight adolescent boys and young men in sub-Saharan Africa. The Voluntary Medical Male Circumcision Program is clearly a program that has served many millions of straight boys and young men, and that is a way to engage them in health care services. I would also plug my colleague Samakaling is here from Lesotho, where we have actually just opened, in collaboration with the Ministry of Health, a pilot healthcare site which is dedicated to men. And it's staffed by all male healthcare providers and serves men, almost all of whom self-identify as straight. And we're seeing tremendous uptake in HIV testing and enrollment in HIV services, ART. The clinic's just been open for about a year now, so if you stay tuned, we'll have data to report there. But it's a comprehensive wellness service. They provide TB services, but also services for non-communicable diseases. And we're finding a lot of success in men. We're doing qualitative work around it, and definitely in that setting, which similar maybe to Swaziland is highly gender segregated, the men report that they feel very comfortable in a male-only clinic environment, and that they perceive the regular outpatient department to be a very feminized space, full of quote-unquote pregnant ladies and crying babies, and not very comfortable for them. And so I think there's maybe some promise with this male-friendly clinic approach.
Thank you. Maybe this side now.
Thank you. My name is Tish. I'm with the Clinton Health Access Initiative. I work on VMMC as well. I have a two-part question on the camps in Swaziland. It sounds like you're doing good work in terms of education and sort of like dealing with social issues. My first question is on reception of the camps from the community around there. Have you sort of reviewed what kind of reception are you getting in terms of like the wider community that you're getting, that you're working in? And the second question is follow-up with the young men that you're working with, because once they're out in the community, I think culture has a sort of like a gravitational force that, you come from a camp, but then you might not always sort of apply the things that you learn. You might have come from a sort of, you might say maybe it's sort of like a bubble, and then when you go out into the real world, it changes. So have you done any analysis on that?
Yes, definitely. Thank you for the question. So question one, community response and family response. We do go out into the communities. We follow up with the young men at 6 weeks, and we talk to their family. How is your son doing? How is he healing? How is he behaving? A majority of responses are very, very, very positive. The second question was also regarding follow-up.
How the camps are received in the community reception.
Yeah, so also we follow up with the communities and with family members, and it's overwhelmingly a very positive response.
Great. At the back.
Good afternoon. My name is Mutinta from Zambia. My question is mainly directed to the last speaker, but I think any one of the presenters up there can actually pick it up. Very good presentation, so thank you very much for some of those insights that you have given us. However, I kind of feel you've shown that there is a gap in actually reaching men, and the recommendation that we need to come up with more strategies, but are you actually able to suggest what some of these strategies actually are?
Well, I think that this is the question that all of us are in our head, no? In our case, the Manisa district is a very specific area inside of Mozambique because we've got a lot of migration to South Africa and also internal migration because, as it was mentioned, we've got a lot of, 2 of the 5 sugarcane companies are in our district. So I don't have the solution, but I think that's something that was especially focused on those men who are not at home or are not working or are not living in the district during the rest of the time. So maybe something focused on ART delivery each year or 6 months or 3 months or something related with the work, with the hours of work. So something like open clinics and male clinics. It's true that we have to go first to try to diagnose them and then try to retain them. And as it was mentioned, I think that men are not comfortable in clinics that have a lot of children crying and men and women. And so I think that we have to go in that side and try to integrate and make men feel comfortable in the clinics and also in the community, because I think that we have to make a lot of effort in the community.
Just to quickly answer that also, with our male engagement strategy, we're now in the sites where we have that strategy, we're getting about 64% of male partners in for the HIV test for the first ANC visit. So that's a huge number of men that we're actually able to capture. The tricky thing is actually keeping them enrolled in care, and that's our next challenge.
Okay, to the front here.
Yes, hi, I'm Denice Manish, working in the Manisa, Mozambique site. And the question was for Carolyn Odette about, maybe I missed it, and I think you may have just answered a part of it, of the proportion of men that actually engage. You said 64%. And I wondered, what about those that don't engage?
It's a tricky thing, yeah. Right now we're at about 64% of men who show up. About 6 or 7% of those are what I would say like bad apples. We wish they didn't come because the women actually have poor health outcomes or testing and treatment outcomes if their husbands refuse to test. So it's like we need a filter system to filter out the bad ones. Sorry, what was the last question?
So it was also, what about those that don't? Do you have any information about those that don't come?
Yeah, some of our men are also doing this thing, like they work in the mines or they work outside. So there's certainly a percentage of men who are not available. And then there are women who just do not want their husbands to come. And so we're going to respect that.
Okay, this side now at the front.
Thanks very much. My name is Charles. I work for Southern African AIDS Trust, but based in Malawi. My question is basically to Ryan, but before I go there, brilliant presentations with some very soul-searching outcomes. I'd like to bring you back to the issue of the camps, which seems to be a very good springboard for engaging the men. But I would like perhaps just a few clarifications from you. Obviously, the camps have got a menu, or the curriculum, if you like. Now, how, and they are called initiation ceremonies. Now, I notice you've given them the label of the camps. How do the two labels reconcile? Secondly, how have you actually engaged with their menu in the initiation ceremonies to build in your program of male engagement? Are they in conflict? Are they in harmony?
Thank you. So we, I guess if we look back multiple centuries ago, male circumcision and initiation rites were a part of society. Young men would be taken away from young boys would be taken away from their communities and their families. They would go away for numerous days or weeks. Not only would they come back circumcised, but they would come back positive, responsible young men. So does that answer the question?
Perhaps a small follow-up. It's within that menu, is there anything within the traditional setup that talks about men's role vis-a-vis the women as well, so that perhaps you could build in your interventions based on maybe the gaps or the deficiencies in that curriculum as they are initiating into adulthood and manhood? Yeah,
so definitely. So I guess to answer that question, I heard a speaker back there earlier say that men are trash and that men are rapists. While in some cases that may be true, I think if we go on that narrative, we're just going to alienate men. I think we should rather provide alternative narratives. Men are positive fathers, men are caring, men are providers. So I think, I guess, showing men that other positive role in regards to their female partners, I think that's what we need to do.
And if I could just piggyback on that quickly, what our study found is that when men were the index client, most of them took the responsibility for informing their wife, not necessarily their casual partners, but definitely their primary partner, that she had been exposed to HIV. And so I think when men do come forward for services, they do take responsibility. And I couldn't agree more that we need to play to their strengths and support them and just recognize the gender norms that they're operating in and work within those gender norms.
Great. At the back on this side.
Thank you very much. I'm Judas. I come from Uganda. I'm a member of parliament. Thank you so much for all the presentations that have been brought forward. I thought men were only missing in Uganda, but to my surprise, I found men missing everywhere, in Botswana, in Swaziland, in France, perhaps also in this room men are missing. But yes, the missing of men is an international concern, and you find them missing across the continuum of care. In HIV counseling and testing, they are missing. In ART, in viral load suppression, they're also missing. I'm happy to announce that in Uganda, we had the fast track presidential initiative that is bringing men on board as the first priority. Sincerely, we don't know. We have to ask men what they want, what works best for them. Because if we don't ask them, then we fail to know what they need. Sincerely, what is setting men back? We want men to really come forward. If they come forward, women will also follow. But now women are the ones leading men. So I think this meeting is very important, that what we are getting here shall be what we have to practice in our respective countries. We have to bring men on board if we are to achieve the 90-90-90. I thank you.
Yeah, thank you very much. So I think there was more of a comment. Maybe let's go to the back again.
Yeah, thank you. My name is Namunda Mutombo from Society for Family Health in Zambia. Mine goes to Dr. Njuguna from Kenya. Two concerns I have for you. I would like you to explain what guided the choice of those 5 counties. Secondly, I would also like you to comment on the external validity of your findings, given that those findings or those counties are coming from, if not all of them, most of them are coming from the South Rift Valley, and a place that is dominated by the Maasais. Your comment, please. Thank you.
Okay, thank you for the question. The choice of the 5 counties is guided by the program implementation area. Those are the areas where the program implements, all of them. So we analyzed all our programmatic data for that time period. So for the external validity of the findings, true, we cannot generalize the findings to everywhere in Kenya, but I think that is the point, that not everywhere is the same. That even when we say that men are missing, they are not missing in the same way everywhere, and not in the same way in all age groups. So I think the take-home message is that in as much as we are saying the men are missing, we need to find out where are they missing, how are they missing, which age groups are they missing, and tailor our interventions based on that, rather than have a blanket tailoring for everyone. We find that that doesn't work. I hope I've answered your question.
Thank you. So I think the people at the microphones now will be the last round of questions. So, yes, please.
Hi, Dean Peacock from Sonke Gender Justice in South Africa and the Men Engage Alliance. It's worth saying the Men Engage Alliance is an alliance of about 700 organizations in about 40 countries around the world, where there are strong networks of organizations who are doing work to promote men's involvement in ending violence against women or in some cases on SRHR, including HIV. So for those of you who aren't familiar with that, fantastic resources on many of these questions on the Men Engage site and on our site at genderjustice.org.za. Make a comment and then ask a question related to it. It seems to me that now over the last 20 years, there's been a gradual and building sense that we've got a real problem when it comes to men's involvement in HIV services. An analysis we did with UNAIDS shows about 37% increased mortality amongst men in South and East Africa. That's a huge problem. And it's one that deserves, I think, many plenary sessions at this conference and the many other conferences. It tends not to get much focus. And so I'm very glad both to see this session and to hear of the wonderful interventions that you've all described. We co-convened with UNAIDS now 18 months ago an expert group meeting in Geneva. We brought together a range of different organizations and UN agencies, and we launched the Platform for Action on Men and HIV, and I'd urge you to have a look at that, including the literature review, which identified many of the programs at that point that were showing some efficacy in terms of getting men in for testing and treatment and keeping them there. And I think what we hear today is more evidence that there are lots of approaches that are working. And frankly, I want to suggest that there's not a paucity of that. We've got lots of evidence of what works from countries across the world now on getting men into programs that advance gender equality, that reduce men's violence against women, and that increase men's participation and retention in care. So the question I have to you is, and it's to other people in the room here, what are we doing to take these programs and increase the impact of them? And I'm deliberately not using the phrase take them to scale, because I think too often we think about taking them to scale within the NGO sector, so simply delivering those services more. But what are we doing to get national governments on board to integrate this into national AIDS plans so that these kinds of interventions are not funder specific for a year or two, 5 years at best with something like DREAMS, and then they disappear? So I'd love to hear from those of you who are doing work to try and get the governments in the countries that you're working in, or the home countries that you represent, to pick this work up and embed it in national policy. And sorry for the long intervention.
Does anybody want to comment? Gail? Do you want to comment or not?
Okay. I can say that for the male engagement strategy, because we piloted it in Zambezia in 2012, and now it is being scaled up by the Ministry of Health in Mozambique. So they were very forward-thinking and forward-looking, and that is something that they're looking at as a national program.
Okay.
Thank you. Oh. Yeah. No. So another small example for the need for tailored attending time, consultation hours outside of the main ones for staff, for example, is also overlapping with the need for men who are working or don't want to be seen with, babies and women in the morning. And so that's what we are working upon together, so that something that was a bit forgotten, that confidential or tailored consultation for healthcare worker, which is a big issue also, and there are many women, but there are stigma issues. So we try to couple things and put it forward together. Then the fact that it remains and is being really integrated, depends a bit in time and size.
The last two, I think if we start at the beginning and then...
Marcel Yotavian, the Ohio State. I just want, because the way I have here the discussion going, just to point that at this same conference, we have shown the data of in this same room earlier before this thing, the data from MPAIH was being shown. We show that men actually, when they know their status and are initiated on HAD, are not very different from women. Their outcome was not very different from women across the three countries that were shown. So when we are talking about it, we need to use what we have been previously. This conference is highlighting the differentiated care. And I don't remember at which session they were mentioning that it's 40% of lost income to men to come to the clinic and wait for the whole day. So it's very important when we are saying that men are missing, that we don't put the blame on the men. We actually have to analyze across the healthcare system and see where it is not targeted for men. Most of our healthcare system in sub-Saharan Africa was designed for primary care and for maternal and child survival. and therefore is not very welcoming for men. You have to go there and spend the whole entire day, which is an entire day of income loss that you cannot do. So I'm just trying to make those comments that as we discuss, we don't lose thing that.
Thank you very much. Good point. This lady, yeah.
Yes, thank you very much. My name is Dr. Ruth Labode. I'm a public health specialist, but I'm also a member of parliament. You know, listening to this conversation about men missing, it reminded me of an initiative that Population Services International in Zimbabwe initiated. The champions of members of parliament being circumcised and it being thrown in the media. It actually increased the number of men who went for circumcision because they saw a parliamentarian as somebody important and thinking, if he can do it, why not me? And I'm seeing also an opportunity, which for my country I think we should do. We have these big political congresses where there are a group of over 10,000 people are gathered and majority are men. If you have this show I've seen here of local NGOs advertising all these things, men at these congresses want the vote. If you let women man those things, and any man who comes there, they say, hey, you have to do this and this, they will get involved because this is how they use women at politics. So use them also.
Thank you very much. I'm going to let this lady ask a question because she's been very patient. Thank you.
Carmen Figueroa from WHO, thanks, great presentation. My question relates to many of the comments that were done, like in how extent did you analyze like if the service has sort of adapted for men, like for example, extended hours or a male representative. I think it goes for most of the panelists because I think it's important that from the services that we offer, services that are adapted not only to men, because that will serve for many other type of population. Thanks.
I think our time is up, so I don't want to get the whole panel responding, but I think it's something that maybe come and ask them. I'm just handing over to my co-chair to wrap up the session.
So these brief presentations that we just heard nicely highlight how gender, cultural factors, and community level processes influence men and their health-seeking behaviors. We learned that men have lower CD4s, longer periods of time to initiate antiretroviral therapy, higher rates of loss to follow-up, and we know that loss to follow-up leads to higher rates of morbidity and mortality. Men also are more likely to engage in sexual risk behaviors that may potentiate HIV transmission or acquisition. And we heard today some successful strategies for engaging men through a variety of mechanisms, interventions, but more attention, I think it's clear, more attention needs to be paid to men's health-seeking behaviors in general. We invite you to go look at the poster presentation, or the posters that are hanging up in the poster room.
Somewhere.
Yeah.
Where are they? They're in the hallway. Just outside here, I think. It's difficult to find the posters, but they're just outside here. Great. So on behalf of us all, I'd like to really thank you. Thank you for the interesting discussion and the comments, and wish you a good rest of the day. Thank you very much.